I'm Dr. Nuzhat Chalisa. I'm an endocrinology consultant, and I will be talking about type 1 diabetes today. So, our objectives here are to understand the etiology, immunology, and pathophysiology of type 1 diabetes. We will talk about how to differentiate between type 1 and type 2 diabetes. We would see how we can diagnose type 1 diabetes. Then we will be talking about different aspects of management of type 1 diabetes. We will be touching upon the technology and the use of technology in the management of type 1 diabetes, and then some benefits of intensive control. So, what is diabetes? Diabetes is a condition in which the body is not able to utilize glucose due to complete or partial lack of insulin secretion. And what is insulin? Insulin is a hormone that helps the cells to absorb glucose from the blood to be later used for energy. In the absence of insulin, glucose cannot enter into the cells and remains in the bloodstream, damaging the blood vessels and various organs in the body. So as you can see here, this slide here shows the interaction between the insulin and glucose under normal circumstances. Glucose enters into the bloodstream from the digestive system. Insulin then enters, this results in stimulation of pancreas to release insulin. Insulin then leaves the bloodstream to bind with the cells, and in the presence of insulin, the glucose is able to enter the cells. So broadly, we classify diabetes into type 1 and type 2 diabetes. Type 1 diabetes is autoimmune mediated. There's autoimmune destruction of beta cells resulting in complete lack of insulin. It is genetically inherited. It cannot be prevented or cured, but you can control it. And there is some role of environmental factors too. Whereas type 2 diabetes, the beta cells make insulin, but cells are resistant to the action of insulin. There is some genetic component involved. However, there is a lot of influence from environmental factors. Type 2 diabetes, on the other hand, can be prevented by lifestyle modification. So you can see here that one may have genetic predisposition to having autoantibodies, but it is only when an immune insult occurs that's when these autoantibodies get activated, and then they attack the cells in the pancreas, and there's rapid decline in the production of insulin. So, as we talked about it, type 1 diabetes, there's genetic factors involved and there's environmental factors involved. The genetic factors mainly involves the autoantibodies. The autoantibodies could be, there are different kinds of autoantibodies that can be involved. There's GAD antibodies, insulin receptor antibodies, mainly involved. And then environmental factors like viral infections, immunizations, perinatal factors like preeclampsia and neonatal jaundice can be involved. So, um, the immunology of type 1 diabetes mainly involves the T cell, it's T cell mediated, and then autoantibodies are involved. And it's the interaction between the T cells and the autoantibodies that leads to the immune reaction. So as you can see here, this shows an interaction between the autoantibodies and the T cells, CD4 cells, which then attacks the pancreas, the cells in the pancreas. And this slide here shows that the T cells arrive, same thing, the T cells arrives in the pancreas and then causing inflammation. This results in insulitis, which then results in the destruction of beta cells and disease onset. So, as we said, since type 1 diabetes is genetically inherited, the lifetime risk for developing type 1 diabetes is significantly increased in close relatives of patients with type 1 diabetes. If you have no family history, your chances of having type 1 diabetes is 0.4%. However, if you're an offspring of an affected mother, your chances are 1 to 4%. offspring of an affected father, it's 3 to 8%. Similarly, if you, in case of monozygotic twins, the chances are as high as 30%. So, how does a patient with type 1 diabetes present? Typically, they will present with a combination of symptoms, including polyuria, polydipsia, and weight loss. They can also present acutely with diabetic ketoacidosis, or they can just be silent and be incidentally diagnosed. And this is a group of patients whose relatives may have diabetes and they get screened during their routine checkups. So, why do we get these symptoms? How do these symptoms develop? So, insulin deficiency basically leads to decreased glucose uptake in the cells. So, there is a spillover of glucose into the blood. The excess glucose is then excreted through the kidneys into the urine. And along with the glucose, there is loss of water resulting in hypovolemia, which leads to volume depletion. The volume depletion then, in turn, can lead to, if it's severe, can lead to diabetic coma and ketoacidosis. Also, because of the lack of insulin, there is increased catabolism in the muscles, resulting in increased production of amino acids, which then provides more substrate for gluconeogenesis, thus worsening hyperglycemia. So classic symptoms includes polyuria. Now, polyuria, there's increased excretion of glucose, only occurs when the renal threshold, when the glucose concentration rises above 180 milligrams per deciliter, which is the renal threshold for glucose excretion. If the glucose is under this level, the kidney is capable of preserving the glucose. In the kids, this may present as bedwetting or daytime urinary incontinence. Polydipsia results in increased thirst, which occurs as a result of increased osmolality from the hyperglycemia and hypervolemia. Weight loss occurs as a result of hypovolemia and catabolism. Insulin deficiency impairs glucose utilization, resulting in increased fat and muscle breakdown, which then results in ketosis. When a patient presents with ketosis, it leads to anorexia and nausea, and eventually this results in weight loss. So the patients with new onset type 1 diabetes frequently present with initial symptoms of nausea and weight loss. So, how do you diagnose diabetes? So, there are two steps in the diagnosis. The first step is to diagnose diabetes. The criteria for diagnosis of type 1 and type 2 diabetes based on blood glucose is the same for both. So, your first step is to establish whether the person has diabetes or not. And that you do by fasting glucose. So, a fasting glucose of 126 or over is concurrent with diabetes. A random glucose of 200 or more, or a hemoglobin A1C of 6.5 milligrams deciliter or more, it causes concurrent with diabetes. Once you know the patient has diabetes, then you move on to step 2, where you want to differentiate whether this person has type 1 or type 2 diabetes. Now, type 1 diabetes, there is no specific test that will clear cut tell you that this person has type 1 diabetes. Type 1 diabetes is basically suggested by clinical presentation, presence of antibodies, and low C peptide levels. Insulin antibodies are present in all individuals who take insulin within 2 weeks after taking insulin. Hence, once insulin is taken, these antibodies cannot be used for diagnostic purposes. GAD antibody is present in 70% of the patients with type 1 diabetes at the time of diagnosis. Type 1 diabetes patients have low insulin and C peptide levels relative to concomitant plasma glucose concentration. However, the thing you have to remember is the C peptide levels may not be low in patients diagnosed early in the course of the disease. Conversely, C-peptide may be falsely low in severe hyperglycemia and acutely ill patients. Best time to assess these levels after is after the newly diagnosed diabetes has recovered from acute illness. We will now move on towards the management of type 1 diabetes. So, how do you treat these patients? Most of our talks will be focused towards the management. So, the management for type 1 diabetes is pharmacological and non pharmacological. So, we will talk in detail about the pharmacological management and then we will touch a little bit on the non pharmacological aspect of it. So, since type 1 diabetic patients do not make any insulin, currently, insulin is the only approved treatment available for type 1 diabetes. Many different types of insulins and insulin regimes are available. The goal is to treat with most physiological regime. Some of the medications that are currently being used for type 2 diabetes, such as GLP-1 and SGLT class, which do not work via the insulin, are thought to be beneficial for type 1 diabetes. But they are currently under investigation, and as of now, none of these medications are approved. So, so what is the basal bolus concept? When you treat patients with insulin, you want to use a regime that is most closer to normal physiological release of insulin. Normally, the body makes insulin all the time, and then when you eat, some extra insulin is released to cover for their meal. That's where the basal bolus concept comes from. So, the insulin that's present in the body all the time is basal insulin, whereas the insulin which is secreted at the time of meal is the bolus insulin. So, as you can see here, the goal of intensive insulin therapy is to mimic the normal physiological pattern. So, as you can see here in the white, this is the baseline insulin. So, this is basically the insulin that's released in response to the glucose that's there all the time. And then every time a patient eats, during breakfast, lunch, dinner, the insulin levels sort of go up. And this is the normal physiological process. So when you're giving insulin, you want to match that pattern. You want to give insulin that stays there all the time, and then you want to give some extra insulin each time the patient eats to cover for the meals. This again represents the same thing. Now, this is again showing the glucose and the insulin spikes along with the glucose in the same way, corresponding way. This is a study that's from Europe, and this is actually showing an extra spike here, and it's because of the tea time. So in Europe, there is a trend to have tea time. So then there is spike for breakfast, spike for lunch, and then a little spike for the tea, and then spike for dinner. And same thing, the insulin is rising along with that. There's a little spike here to cover for that tea time. So So, what does the basal insulin do? The basal insulin's job is the suppression of endogenous glucose production, suppression of lipolysis and ketogenesis. And so, the basal insulin controls glucose between meals and throughout night. And then this sort of represents the bolus insulin. So as we can see here, the bolus insulin, so this is the glucose spike, and along with the glucose spike, there is a spike in the insulin. And this is how the insulin analogs or the short-acting insulin works. Now, there are many different kinds of insulins available. The management of diabetes has dramatically changed in last 10 years. If you go back like 10 to 15 years, we only had like a handful of insulins that we had to work with. Now we have a whole big list of insulins. So basically, there's the short-acting insulins or the mealtime insulins. You have rapid acting and short-acting. The short-acting is the regular insulin, whereas the rapid acting are called the insulin analogs, and they are the lispro, aspart, and glulisine. The basal insulins are the intermediate acting and long acting. The long acting insulins are the glargine, which comes in U100 and U300 forms, and then you have the Detrim and the degludec. Whereas the intermediate insulin is the NPH insulin. The NPH insulin sort of lasts for about 14 to 20 hours, and so it has to be taken twice a day to provide a 24-hour coverage. Whereas most long-acting insulins actually last for 24 hours, and so they don't have to be. They can be taken just once a day, and some of the insulins actually even last for longer than 24 hours. So The difference between the U100 and U300 is that the U300 is much more potent than U100, and so it is beneficial in those patients that are on higher doses of insulin. The U300, if they take U300, they have to take much lesser volume of insulin, and so that results in better absorption. Then you have the pre-mixed insulins. The pre-mixed insulins are like mixtures of NPH and regular or deep glutamate and aspart. So basically, the basal and the bolus insulin are combined together. Um, Here, there is the little advantage here is that you don't have to take as many injections, but the disadvantage is that if you want to change just your basal or bolus insulin depending upon your blood glucose levels, you can do that because you will end up changing both the insulins at the same time. So this is sort of an older form of insulin, and its the use is discouraged at this point because of the higher risk of hypoglycemia. So again, looking at all the insulins, this red line here shows the action of the long-acting insulin. As you can see, there is no peak, and so since it doesn't peak, it has minimal risk of hypoglycemia. Then in blue here is the NPH or the intermediate insulin, which is action kind of lasts to about 14 to 16 hours, but it has a peak here. So whenever you have a peak in the insulin, it's always associated with the risk of hypoglycemia. Then you have in the green here is the regular insulin. Now, the green and the yellow represents the bolus insulin or the mealtime insulins. But you can see the regular insulin here. The action starts almost 30 minutes after the insulin is taken. So this insulin has to be taken 30 minutes before the meal in order for it to coincide with the levels of glucose. And then you can also see that this action, the action of this insulin kind of lasts a little bit longer, up to like 6 to 8 hours. And so sometimes this can overlap with the next dose of insulin and result in hypoglycemia. Again, regular insulin is an older form of insulin. We have insulin analogs now, which is represented by the yellow line, which are much faster acting. You can see here that it starts working rapidly, it peaks, and then it ends very quickly. Within 4 hours or 4 to 5 hours, it is gone from your system. And so there's much less risk of hypoglycemia with the insulin analogs. This slide here again represents the same thing, that as your glucose go high, you want to match that pattern and you want to give your insulin in the same way to cover for the high glucose. So how do you calculate the dose of insulin? Basically, basal insulin in type 1 diabetic is the requirement is usually between zero point 0.3 to zero point 0.7 units per kg per day, an average dose of zero point 4 units per kg per day. 50% of the total insulin should be basal. So mostly the basal and bolus insulins are divided half and half. Sometimes they are taken in a ratio of 60 to 40. This insulin requirement is influenced by several factors. So your activity level, residual insulin secretion, stress, menstrual cycle, growth hormones, and your circadian rhythm. Kind of determines the ratio that you use. So bolus or prandial insulin, how do you calculate the dose for your prandial insulin? So the dose is basically adjusted based on your carbohydrate intake and blood glucose level. We call this the carb to correction ratios. So the way this works is we have to calculate the insulin to carb ratio. That means units of insulin needed to cover X grams of carbs. And then you have the correction factor, which is based on individual sensitivity to glucose, which means that how much glucose 1 unit of insulin will drop for that particular individual. So the total bolus dose is the dose that's taken based on carbs plus based on correction. So based on the carbs intake plus the based on the blood sugars, and that would be your total bolus dose. Sliding scale has been used in the past, which is a sort of a way of giving insulin based on your blood sugar levels only, without taking into consideration carbs, and that's sort of getting obsolete, and it doesn't work that well, and it's not recommended. So this slide just shows your various ways you can take insulin. This is your generic way of taking insulin, your insulin vial, and you take it with the help of the insulin pens, which are a little bit different than your regular insulin syringe. I'm sorry, insulin injections, which are a little different than your regular insulin, regular injections. And then this picture here shows your use of an insulin pen, which is very common. And these days we pretty much don't use insulin syringes unless there's a specific reason for it, as the use of pen is becoming widely used. And then so the insulin pen basically has a shorter needle, and there's a cap here, so you basically have to just cap the needle, and then you have to adjust the dose just by turning the little cap here, and then you just have to push the button and take the insulin. um, this here is an insulin pump. So the insulin pump gives a set amount of insulin throughout the day, and then most pumps are attached to a glucose monitor, which transmits the information directly to the pump. So when the patient checks the glucose, the information is transmitted directly to the pump, and then the patient has to enter the amount of carbs into the pump and the pump then calculates the dose. So basically, instead of the patient calculating the dose, the pump calculates the dose, and it tells you how much insulin to give. The patient then goes and just pushes a button and then gets the same amount of insulin. um, there are different several kinds of pumps available these days, and the latest kind of the pump is the hybrid pump, which comes with the glucose monitor. And not only this pump monitors the glucose, but it also self adjusts the insulin dose based on patient's glucose level. Monitoring blood glucose. So, self monitoring of blood glucose is as important as taking insulin or any other management. It is recommended for all patients with type 1 diabetes. It involves capillary blood sampling with the help of a glucose meter. Ideally, testing should be done before each meal and bedtime. Additional testing is advised before driving or before performing any strenuous physical activity, or whenever the patient has symptoms of hypoglycemia. The goal here is to maintain fasting and pre-meal glucose, fasting glucose under 120, and 2 hours after meal glucose under 180. Those are the standard of care for both type 1 as well as type 2 diabetes. The goal is modified upon individual basis depending on patient's age and presence of other comorbidities. For example, if a patient has for an older patients, we usually don't keep the goal that tight. Similarly, patients who have severe cardiovascular disease or severe renal or chronic kidney disease, the goals are usually made more lenient. Continuous glucose monitoring is also becoming very common, and there's been a widespread use of continuous glucose monitors. Glucose is monitored continuously through these every 5 minutes from the interstitial fluids. Some of these devices have alarms for high and low glucose. This can transmit data to the patients can transmit data to their cell phones, which allows to share the data with the other family members in real time. Also, several monitors are available. Freestyle Libre. This is a Freestyle Libre, so it's like a button that goes on your arm. It sticks to your arm. There's no needle here. There's a small catheter, and then you just have to take your phone close to download the app and take the phone close to it, and you'll get your reading here. This is a mini med sensor, which works. It's a continuous glucose monitor that can be used by itself, or it can be used with the help along with a pump, where the pump and the sensor talks and the information is transmitted. So CGM monitors allows immediate feedback of glucose and early intervention in treating high and low glucose and avoid severe hypoglycemia. Labs monitoring for diabetic patients. We recommend hemoglobin A1C and a comprehensive panel to be checked every 3 months. Lipids and urine microalbumin levels are usually checked annually. Hemoglobin level is the average glucose that the patient has had in last 3 months, and it is basically the glucose bound to hemoglobin, and therefore changes in hemoglobin levels can falsely raise the levels or lower the levels of hemoglobin A1C. For example, patients who have anemia due to chronic kidney disease, they may have, since they have low hemoglobin, they may have falsely low levels of hemoglobin A1C. Similarly, it has been seen that patients with iron deficiency anemia, on the other hand, have falsely high levels of hemoglobin A1C. There are many other factors that can influence the hemoglobin A1C levels. Um, Diabetes education. All patients with type 1 diabetes need to have some sort of diabetes ongoing self management education and support. Nutritional counseling is one of the most important components in management of diabetes. Patients should be able to estimate how much carbohydrate they should consume at any meal or snack. It is important for the patient to understand the effect of the diet, physical activity, and stress on blood glucose levels. And prevention and management of hypoglycemia is another important thing that all patients should know. Prevention of diabetic ketoacidosis, sick day rules. Again, when patients get sick, it's very important that to instruct them that they're supposed to continue taking their insulin if especially if they have type 1 diabetes. A lot of times when patients get sick, they're not eating well and they assume that they should not be eating, they're taking the insulin. But in type 1 diabetes, since they don't have any insulin, this can result in diabetic ketoacidosis. So patient must always take their basal insulin. They should check the ketones if the blood glucose is over 250, drink plenty of fluids, and then take the bolus insulin levels can be adjusted based on their meals or the amount of carbs they intake. There's many psychosocial issues associated with both type 1 and type 2 diabetes. Patients with type 1 diabetes experience significant stress related to self-care and optimizing glycemic control. Depression, anxiety, and eating disorders may develop and associated with poor glycemic control. Support from family, friends, and healthcare team are all important in the successful management of type 1 diabetes. A little bit on the complications. We know both type 1 and type 2 diabetes are associated with both microvascular and macrovascular complications. Microvascular complications affects your eyes, kidneys, and neuropathy. So basically, it affects the small vessels in these organs, resulting in retinopathy, nephropathy, and neuropathy. Whereas the macrovascular complications occurs due to affects the larger vessels in your heart, brain, and extremities. And this graph here represents the DCCT trial, which was one of the largest and the longest trial in the history of diabetes, which has uniformly showed that intensive control of diabetes prevented complications across the board and reduced mortality. This again shows here that the DCCT trial, after the DCCT trial ended, the patients who participated in this trial, they were monitored long term for many years after the trial ended. And it was seen that patients who were getting the intensive control in DCCT trial, they did much better in the long run, even after their trial ended, compared to the patient on the control group. And this is what we call a metabolic memory, which means the body remembers the time of the good control and sort of maintains that good control. That good control is maintained long term. Intensive glucose control, it favorably changes the biology of blood vessels, proteins, and DNA. Lag time of 10 years before the effects have clinical benefit, and good glucose control early is likely to have a greater impact than after complications are present. So, just to summarize, um, diabetes is broadly classified into type 1 and type 2 diabetes. Etiology involves genetic inheritance and environmental factors. Type 1 and type 2 diabetes can be differentiated on the basis of clinical presentation, presence or absence of autoantibodies, and C-peptide levels. Pathophysiology is immune mediated through CD4 cells and autoantibodies. Diagnosis is based on fasting glucose, random glucose, or hemoglobin A1C levels. treatment with insulin, preferably basal-bolus regime or insulin pump. Monitoring diabetes education and nutritional counseling is equally important. And finally, intensive control prevents complication. I thank you so much and good luck to all the medical students.